make sure you go through table 5.1, advantages of good communication. Like, what do you think will be the advantages of good communication between a patient and doctor, between a doctor and patient? Tell me in the chat box what is your understanding about a good doctor patient communication. What do you think will be the advantages of having a good doctor patient communication? From your understanding, give me some points, everyone, in the chat box. Empathy, consents are part of communication, but how is it advantageous? Okay, what is a good outcome? Helps in recovery. Yes, true. Not in all cases, but good patient care. True. Will the patient be satisfied? Yes, there will be trust built up, satisfaction, feeling of empowerment. When there is a good communication, the patient themselves will feel they are also in control of making good decisions about themselves. Will the patient follow all the guidelines if they are given proper communication from the doctor's side? Whatever the doctor says, will the patient follow at home if communication was proper? Yes, they will. They will stick to their treatment plan. Okay. Will the patient be loyal even if the treatment is not working, like it's immediate recovery is not happening, but still if the communication, there was a good doctor patient relationship, okay, the patients will stay loyal to that treatment plan. Even if it takes time, they will stick to the treatment plan, they will stick to the same doctor based on the communication which they had, the communicative doctor patient relationship which they had maintained. They will not go for the second opinion or second doctor just because this is not working, I am going for second opinion. Okay, so that is how you get loyal patients to your hospital. Okay, and there is less chance of complaints and legal actions which the patients may take against the doctor. If the patients know that everything was communicated to them, whatever information was needed in their case, everything was communicated to them, the doctors didn't hide anything, there is very less chances that if anything goes wrong, these patients will go and sue the doctor. Okay, so these are the advantages of good communication. Okay, so also what the patients want from a doctor, that should be known. Okay, so the patients want a good, clear, and a positive direction to take their health to a better level. Okay, so they want that kind of guidance from the doctor. They want a doctor who is listening and very attentive of their emotional displays, their physical displays, etc. Okay, the doctor should be honest, empathetic. Okay, provide all the information, or not just information, what all different treatment the patient have access to for this particular condition, what all different types of treatment the patient may have access to, everything should be listed out. So these are the things the patients will require from the doctor's side or from the healthcare management side. Okay, so these things have to be taken care of. So again, there is another table, that is table 5.2, that will have all the list of the things that your patients are looking forward from you. Okay, so just go through these two tables, table 5.1 and table 5.2. Both these tables are on page number 30. Very easy, just read through that, understand it, that is more than enough. Okay, next, barriers in communication. Lack of time. Can anyone say what will be the reason to it? Lack of time. Lack of time on whose part? Doctors or patients? This is one of a very common barrier which we in India are facing. Yeah, from the doctor's side, because of, even if in public hospital, or in private hospital, that is overcrowding. Okay, the doctor patient ratio in India, you know how it is one doctor for every 1,000 patients. That's a very low ratio. Okay, so given to the statistics of this ratio, just imagine how much time a single doctor can pay for us throughout their entire day for 1,000 patients. Okay, hardly few minutes for one patient, and that few minutes are not enough to carry out the entire past history, the family history, health history of the patients, to do a complete physical assessment. Okay, there is a lack of time. Okay, so that is an issue which we are facing. If there is a very less time for each doctor to pay attention to each of their patients, obviously the communication made in such short time will not be that beneficial. So that is one barrier. Second, arrogance. From whose side again? From doctor's side or patient's side? Arrogance. Do you understand the meaning of arrogance? To be rude. Okay, doctors, patients, both. Okay, nowadays our patients are over informed, not just well informed or informed, they are over informed because of the n number of information available on internet. Okay, and also rising cases of violence against the medical fraternity. Okay, so arrogance is nowadays seen from both the sides, but in textbook it is given from the doctor's point of view. Sometimes the doctors may think that their patient knows everything, there is no need to explain much. Okay, even if the patient has doubt, okay, it will not be taken in a positive manner from the doctor's side. These are certain barriers which has to be taken care of. Okay, shyness. When there are when certain information which are quite intimate in nature has to be shared from the patient side, as well as the doctor want to know certain intimate information from the patient side, there may be a barrier of shyness from both the parties. The doctor may feel very shy and awkward to ask such an intimate question. The patients may also be shy and awkward to state an intimate response for that question, because physical assessment, certain physical assessment, certain family history, patient history, okay, there will be intimate questions also in such a communication. So shyness can be a barrier. Okay, just to avoid that questions, you will come because of shyness you will completely avoid that questions, and that may lead to some mis judgment in treatment. Language jargon. What do you understand by that? Anyone? What do you understand by language jargon? In the chat box. That is one thing called as language barrier, very common in India. Okay, because we speak a number of languages. If you are moving from one state, one district to another state, just for a treatment, to get a better treatment, there will be language barrier. What do you mean by language jargon? It's basically using, yeah, too much of scientific terms, using too much of medical terminology. We may be knowing that better because we were in the science background, we were educated in the medical background. Okay, those people will understand, but not the entire population in a country or the world is being educated with medical terminologies and all. Okay, so when a doctor is explaining the condition of a patient to the patient or to the patient party, try to use words that are from a layman's language. Okay, the language which you use to communicate at home and all. Okay, that kind of layman's language should be used to explain about the patient or to the patient family about the conditions, treatment, diagnosis, and everything. Do not focus more on medical jargons. Okay, the patients may nod in front of you because they don't want to look stupid in front of their doctors. They may not ask questions, they may not ask doubt, they may not ask to clear that what does it mean, because they don't want to seem stupid in front of their doctor. But that's not the case. We have to understand that, use layman's language while explaining things. Okay, deafness. There are two cases of that. When you are treating a patient who has this physical challenge, and another case is when you are treating Senior citizen, when people grow old, they slowly lose their ability to hear properly. So when you are treating someone beyond the age of 60 or 70, make sure that they are able to hear you properly. You may have to use some voice modulation in speaking with them. Certain things you may have to speak loudly. Okay, so make sure the doctor should use voice modulation whenever and wherever it is necessary. Phones, how do you think phones will be a barrier to communication? In the chat box, anyone? How phones are a barrier to communication? It's very simple. Yeah, using phone, like when you are speaking to someone, not just doctor or patient, even at your home environment, with your friends, anywhere, when you're speaking with someone in you are very in a very good communication space, and achanak the phone rings. Okay, suddenly the phone rings, and the person may be looking through the phone, no nodding at you, but looking through the phone, scrolling down the phone. How will you feel? Okay, you don't feel like you will know that they are not too attentive. If somebody is not too attentive, you will also lose interest in the communication. So this happens. Earlier days, we had telephones, landlines, and the receptionist used to handle all the calls, so the doctor was not interrupted. But nowadays every doctor will have their phones in their pockets. Okay, so whenever a patient consultation is going on, their phone goes off. It is very common. Okay, their phone goes off. They may have to attend. It can be an emergency. Okay, they can't switch it off, or they can't just cut the call. It can be any form of emergency. So that is how phones turn into a barrier. Information needs. What do you understand by information needs? For certain people, they are quite knowledgeable, quite understanding. Very less form an amount of information is more than enough. Okay, but for some people, so for some patients, they want to know more and more. How it happened, why only I am suffering from this, how did this disease catch me? Okay, you may have to go into their genetics, into their family history, explain them the family history also. Sometimes the patient knows, okay, I have certain family history of this disease, that is why I think so I am also affected. Okay, so that is how information needs will play out. Okay, different patients will have different types of information needs. Okay, they want to know all the treatment possible. They will go for second opinion, third opinion, etc. Okay, that is information needs. So the doctor is not able to identify exactly what the patient wants to know, how much the patient wants to know, how much they are understanding. Okay, these all things may be a barrier. So strategies to improve communication. How can we improve the communication? First, check what the patients know. What are the basic knowledge? How much they know about their condition? Okay, even before the diagnosis, do they have a tingling or an intuition that okay, they may be suffering from so and so disease? Okay, how much the patient knows? And sometimes it is very important to know this point, especially in today's world, because there is a lot of misinformations available on the internet. Okay, even if whenever you are having certain symptoms, okay, instead of directly first going to the doctor, you will try to google things, you will try the internet to understand these and these signs and symptoms means what disease. Okay, and you know how the google search results are. It is very rarely anything positive. Even a small cold can lead to a very chronic disease condition in a Google search. So that is how we have misinterpreted the information available in the internet. So when a patient is coming to a doctor, finally, okay, the doctor has to understand first how much of misinformation, how much of misinformed this particular patient is. Clear those misinformations first, and then proceed for the diagnosis and treatment. So that is very important to understand what the patients already know. What they know is a good information or is it a misinformation? Then what they want to know, okay, they may be knowing so and so things, and what else they want to know, what all treatment they have option for, is it survivable, it can be treated or not, is it a lifelong disease, okay, what to be done, how can I prevent myself from transmitting this disease to others, okay, all sort of whatever questions the patient may have, answer that. Assess the understanding. What do you mean by that? Anyone in the chat box? Now you have explained everything to the patient. How will you assess the understanding? In the chat box, anyone? How will you assess the understanding of a patient or a family member, anyone with whom you just had a conversation with? You want to check if your information was well received as you intended to. Okay. How will you assess the understanding? Very simple. Or not just patient will accept, because even if the patient has not understood things, he may think, okay, doctor is someone who knows everything, let him do what he knows the best. It's better if I don't know anything, let him do what he knows the best. The patient may think that. So acceptance doesn't mean understanding. Like, you have to assess the understanding. Think about it. If you have explained something to someone, you want to check if they have understood the point or not, what will you do? Anyone in the chat box? Yeah, from the response, and also ask questions back to the patient. Okay, yeah, get a feedback, ask questions. Sometimes ask the patients to explain things which the doctor have said, explain it back to them. Because the doctor may say, okay, whatever I have told you, you are just nodding. Tell me what you have understood. Okay, you can use this kind of statement to make sure how much the patient has received the information. That is very important. Okay, if they have missed certain important points, some cautionary points, etc., okay, if they have missed it, again you have to restate those points. So assess the understanding means asking questions. Okay, at the end of the communication, ask questions. Okay, make sure you ask them to explain back the strategies, so that you will know how much the patient have understood the concept. Okay, listening skills, no need to explain that, everyone should have a proper listening skills. Okay, don't directly try to interrupt the patient when they are telling their story. Okay, whenever they are telling that these are the psychological problems which I had, these are the emotional experiences which I had, these are the physical symptoms and signs which I'm having. Okay, let them complete their complaints, everything, and then you go into the conclusion. Okay, so don't try to interrupt the patients when they are speaking about their issues. Build confidence, that is just by proper listening. Okay, if you have a good listening skills, automatically you will build a good confidence in your patients. Okay, truth, there are certain things like, if I say, if I will get a patient to a chamber and tell, okay, tomorrow, within few days you may die because of so and so disease, and there is another way of saying it, counseling them and then giving them the information. Which will you choose? In both the case you are telling the truth. Okay, in both the case you are delivering a bad news. Which is a better option? Being harsh and bold, or using counseling as a solution first and then delivering the bad news? Obviously counseling. Okay, you have to speak, you have to be honest with your patients, you have to be truthful to your patients, but there is a way of doing it. Okay, simplicity and clarity, same thing. Try to avoid using medical jargons in your communication. Don't use too much of medical terminologies in your communication. Keep your communication as simple as possible in a layman's language. Keep it as simple as possible. Tolerant, sometimes doctors are the first one who will assess, who may have to witness the anger that comes to in the patient's emotions when they deliver them a bad news. Okay, if somebody is suffering from a very chronic disease that doesn't have any cure, okay, and you have just delivered that bad news, so the doctor has to be tolerant and has to accept the fact that now the patient will go into an emotional phase that may be very dramatic, very emotional, torn up. They may break down and cry, they may go into an anger spurt. Okay, they should be very much accepting that these are the certain responses which uh, the doctor is going to accept. Okay, the doctor is anticipating. So in that scenario, you have to be tolerant, you have to allow your patient to vent out their feelings. Okay, to vent out the feelings, but obviously without causing any harm to the people in that particular room. Okay, no physical harm or no much of verbal abuse should be there. Apart from those things, you can allow the patient to vent out their emotions. Empathy, what do you understand by empathy? It's a very common term which we will be using so many times in this particular book. Empathy and sympathy, what do you understand by empathy and sympathy? What is the difference between this empathy and sympathy? In the chat box, anyone? Difference between empathy and sympathy? Yeah, empathy means putting yourself in others' shoes. Okay, feeling pity for someone is sympathy. Okay, feeling pity for someone is sympathy. Empathy means putting yourself in their position. Okay, putting yourself, thinking after putting yourself in others' position, putting yourself in others' shoes. That is empathy. Sympathy means to have a pity. It's a feeling of pity for someone. Okay, so that's the difference. So in medical terminology, you do not have to be much of sympathetic. Yes, you will feel pity for others. Okay, but you, when you're delivering certain news, you have to be empathetic. Okay, you have to put yourself in their shoes and understand, when if you will receive such and such information, how you may react. Okay, and when you are empathetic, you are more tolerant and you are more accepting of others extreme emotions, apart from being physically harmed or verbally harmed. Next is family conference process steps. When you have to speak or give certain information, not just to the patient, but that information includes their family members also. Okay, so why do you do family conference process is, first you have to identify what your goals are. At the end of this conference, at the end of this meeting with the patient as well as his or her family members, what are the things we should achieve by the end of the meeting? Each and every family member and each and every people who were there in this particular meeting along with the patient should understand everything about the condition of the patient. That should be the goal. So that is the why part. Where do you think the family process conference will take place? Will it take place in the open, or it will take place in a very closed private area? Where do you think these family conferences with doctors, family members, and the patients will take place? Will it take place outside in the corridor of the hospital, or will it take place in a very private room with privacy? Okay, it should take place in a room where others can't hear. People apart from the family or other patient parties or other patients or other staffs who are not involved in this case, they can't hear what is going on. Okay, this kind of family conference, you will invite the family to a particular room, particular chamber with proper privacy, proper sitting arrangement, allow them to sit, be calm, and then deliver the news, good, bad, or any future planning with the treatment, anything. Okay, it has to be done in a private space. Who all will be present in such conferences, such meetings. Okay, first the doctors will be present, the treating doctors. Sometimes social workers may be there, family members, patient. In certain cases, patients will not be there if the doctor has not delivered some bad news to the patient, and it may take time to reach the patient. You have to first deliver the news to the family member consent, and slowly you have to deliver the news to the patient. Okay, so who and all will be there? The treating doctors, social workers, a medical representative or a lawyer. And there's something they have not wrote here, but it should be present in today's scenario. There should be a security guard who should be present outside this room. Okay, because if there is a tragic news which is going to be discussed in this conference, the family members can turn violent and put the doctors as well as the medical staff at the risk of physical violence or any assault. So in that case, there should be a security guard present outside this room. It is not mentioned here, but in practicality, there should be, given the times which we are living. Okay. So the members who should be there in this particular conference is mentioned in the third point, page number 34. Just go through that. Introduction. All the members who are there in this particular room, okay, should be introduced. Sometimes there will be the treating doctor will be the resident, and a specialist may be involved. The specialist may not know who all the family members are. Okay, so family members may be seeing this particular specialist for the first time. Okay, so in that case, the resident who knows the family members can introduce the specialist to the family members. So the patient's case is quite serious. So this is the doctor who is specialized in particular department. He will be taking care of the condition, and these are the family members. Is this the mother, husband, like that? Whoever is the family present, introduce them to each other. Okay, at the end of this introduction, everyone should know who is who. Okay. Knowledge level, check the family members or the patient's knowledge level, how much they know about that condition the patient have, what treatment the options are available. Okay, so all this knowledge level has to be assessed. And review the medical status. After assessing the medical level of knowledge, wherever there is a gap in the present knowledge and the knowledge you want to give, the news you want to give, after that, do a review of the medical status, the current status of the patient. After doing so and so treatment, will it improve or will it deteriorate? What are all the extreme cautionary steps we have to take? Okay, what things can go wrong while doing this treatment? Everything has to be explained here. So that was a family conference. And when you wrap up this family conference, summarize everything you have talked so far. Okay, the plans and the decisions you have for the future for this particular case, and cautionary steps. What are cautions against any unexpected outcome? For example, I said earlier, if it is a bad news, the patient family is not taking it properly, one cautionary step which you should have is having security nearby. Okay, family spokesperson, identify that, because in most of the cases, for example, if her husband is admitted is in a very critical condition, the wife may be completely born out of emotions. She may not be too receptive of the communication because of the emotional trauma she may be going with. There should be some other family members in supporting her, but who are much more vigilant about things happening around the hospital. Okay, so someone who can take decision on behalf of the wife's part. Okay, so that is how you identify the family spokesperson, the person who is very close to the patient admitted or in a critical condition, may not be in a mental state to receive information, to take a decision or of what should be done. In that case, next to the kin who is much more emotionally strong, okay, that who they have to be identified, and uh, they are considered as a spokesperson for the family. All the important decisions and important information will be given to this spokesperson. They will discuss with the family members and they will come back with the response. That's how it works. And then document everything, all the key points which took place in the meeting, document everything. So delivering bad news to the patient. First, you should have a physical setting. Again, same. Have a quiet, comfortable room. Okay, turn off your mobile phones and everything, because during at least at this time there should be no interruptions. Check your personal appearance. Okay, you should be also calm. Have a participant along with you, one more medical staff, while giving a bad news, and make sure all the parties are sitting down when they are getting this bad news, because if they are standing and it's something that cause a emotional trauma, they can collapse and cause a physical harm to themselves or anything, so that has to be avoided. So goals of the of delivering the bad news is, make sure that the person who is delivering the bad news, sometimes it may be the resident or the specialist, whoever is delivering the bad news should know the entire case. Okay, the entire diagnosis from the time of point of admission till the current time, all the case, all the details should be known. Circumstances, for example, there is a language barrier. Okay, the language which the doctor is speaking, the language of the family or the patient party is not the same. In that case, arrange for a interpreter. Especially when you're delivering a bad news, you have to make sure compulsorily there is a interpreter. Self reflection has to be done. For example, it is very common even for the doctors to have very strong emotions, especially when they are treating a patient for a very long time. They had hopes high, even doctors had their hopes high, and they may be losing the patient. In such cases, having a strong emotion is very common from the doctor's side. Also, they have to be trained in that perspective also. It's normal to have strong emotions, but do not show your strong emotions in front of the patient party when you are delivering a bad news. So that is self-reflection and emotional reactions. Ventilator withdrawal. So outcome, can anyone say what will be the outcome of ventilator withdrawal? Majorly, there will be two outcomes. Anyone in the chat box? When you take away the ventilator support, one is patient death, and another outcome is sometimes the respiration, the normal stable respiration can be achieved. Okay, these are the two possible outcome of ventilator withdrawal, either death within few hours or within few minutes, and sometimes you can in some fortunate cases you can get a stable respiratory outcome. Okay, so outcomes of the ventilator withdrawal should be mentioned when you are going for a ventilator withdrawal process in certain cases. Okay, usually it will be the cases of brain death cases and all, where you know the patient cannot survive, or in certain other critical cases where or sometimes when the patient is going to come back to normal, you know that, and you may be withdrawing the ventilator in that case. So procedure, the procedure that it takes place is, first inform the patient party about that you're going to put the patient out of ventilation, mechanical ventilation. That has to be informed. Do not take the ventilation of the patient without informing the patient party. Okay, so even if it is planned or unplanned, patient party's involvement should be there in the decision making. And explain to the patient party that whenever you are removing the ventilator, breathlessness will be there. You will see that in the patient trying to breathe more air. Okay, they will be striving to get more breath. So in that can be managed with oxygen therapy or other management. Okay, other drug management, it can be managed. So the patient party should not panic when they see breathlessness in their patient. So that's how should be the procedure before you withdraw the ventilator. Every possible outcomes, every possible signs and symptoms, as soon as you withdraw the ventilator, everything has to be explained to the patient party. And you can also tell them that if at all it is a ventilator withdrawal that is going to lead to death, okay, in that case you can tell your patient party that they can show their love and affection to the patient by touching their forehead, holding the hands, wiping the patient's forehead, okay, like that they can show their affection. Support the decision. When the family member has given the consent for ventilator withdrawal, support their decision, okay, ensure that they are doing the right thing, because at the last moment they may second guess themselves when the ventilator has been is been removed, and when the ECG goes down, okay, when the patient party observes all these signs, they may second guess themselves, and they may panic and try to stop the ventilator withdrawal process. Okay, so in that case you have to be supportive, you have to console them, tell them, reassure them that their decision was the right thing to do for the patient's health. Consent is very much required, especially informed consent in their own language. They should understand what is the outcome of this particular process, why they are doing it, what is the outcome of this particular process in the language which the patient party understands. In that format, consent has to be taken. So next chapter will be doctor-patient relationship, that is chapter 6 on page number 38. Chapter 6, page number 38. So just the introduction of this doctor-patient relationship, it is the attitude towards patients. Okay, courtesy. What do you understand by courtesy? Basic courtesy. When you visit a doctor's chamber, do they wish you good morning? Does the doctor say hi? Does they say, do they tell you to please sit, please take a seat? Okay, so these things are basic courtesy. Consideration, compassion, respect. Okay, without coercion. What do you mean by coercion? COERCION, coercion. Yeah, whatever you want your patients to do not force anything on them. Okay, don't make them do things forcefully. Okay, do not discriminate them based on caste, creed, religion, race, socioeconomic class, etc. Avoid harassment, okay, or any forms of exploitation. Respect your patient's privacy, dignity. Okay, maintain a professional demeanor always. Do not cross the border with your patients when it comes to the doctor-patient relationship. Usually the doctor-patient relationship ends with the end of treatment and follow-up. Okay, after that, the doctor-patient relationship should not continue. That is how you maintain a professional demeanor. Do not retaliate unless and until it is for self-defense against any physical harm. Do not retaliate. Like retaliate means give an aggressive response back. Okay, so do not be aggressive or try to defend yourself until and unless it is for any against any physical harm. Fiduciary relationship. So fiduciary relationship means the patient completely, he or she will completely entrust their health in the hands of their patients, knowing that the doctor is trustworthy. I can trust my health with the doctor. Whatever decision the doctor will take will be in my best interest. That is fiduciary relationship. That relationship that is based on confidence and trust. Okay. So fiduciary duty of the doctor means you have an obligation to act in someone else's best interest. They can't take the choice. Okay, they are not able to take the choice what is best for them, but you have to take the best choice for their health. That is the fiduciary duty. So a doctor must act in good faith, care, and loyalty. If a doctor fails in his or her fiduciary duty, what will happen? If what happen if it is breached? The doctor may be sued. Okay, Legal action can be taken against the doctor, may lose their credentials, may lose the license of practicing medicine, and if found criminal, if found guilty, may go to prison or may have to pay penalties. Okay, so the medical profession comes with this fiduciary duty. It works on this fiduciary duty. Okay, whatever actions you take, whatever decisions you take, is not for your best interest, it is for the patient's best interest. That is fiduciary duty. Okay, and this kind of duty is not just between patients or doctors and patients, it is also between these examples which we have mentioned here, like an attorney, a lawyer, client, okay, director of a institution and the shareholders, trustee and the beneficiary, guardian and ward. In case of guardians, like can be either parents, or in case of any adopted child or mentally challenged person, a guardian can be someone court appointed guardian. Okay, whatever decision the guardian is taking should not be for their best interest, should be for the best interest for the ward, investment advisor and the client. Okay, so this is how fiduciary duty works. Apart from the medical healthcare system, these are the other areas of where the fiduciary duty has to be followed. So traditional concept of doctor-patient relationship, what used to happen in the olden days? How was the doctor-patient relationship in the olden days? Okay, we have a few theories in this. Okay, so Parsons theory. To understand Parsons theory, just you make a note of page number 39, table 6.1. Page number 39, table 6.1, Parsons theory. When you read that table, you will understand. I will just briefly explain Parsons theory. So this is a traditional concept in which Talcott Parson, he was a social scientist. Okay, he had made this theory that there is an ideal patient and there is an ideal doctor, and there are certain duties which has to be done by the ideal patient. Okay, and that duty is to completely be submissive of the doctor's decision. And in Parsons theory, what Parson was telling is the patient doesn't have the capability to make decision for himself or herself. Okay, they can take leave from their social responsibilities just to get treatment and come back to the society. Okay, and they cannot take any decision about their health on their own. All the decision about their health has to be taken by a expert and knowledgeable doctor. Okay, so here a patient is a passive person who completely submits himself into the care of the professionals. Okay, that's how Parson describes an ideal patient. Okay, on the other part, and he also says that the patient has to completely cooperate with whatever decision the doctor is taking. Okay, do you agree with that kind of ideal patient? In the chat box, what is your opinion to this particular theory? The patient should be completely submissive to the doctors, completely cooperative. The patient is not capable of making any decision for himself or herself. What do you think? It doesn't hold true for certain cases. For example, if this patient is a comatose patient, okay, or a patient who is under anesthesia, in coma, okay, in that case, obviously the patient is completely under the care of, under the decisions made by doctors. Okay, in that case this may apply. Okay, because the patient doesn't, obviously the patient is incapable. In this particular situation, the patient is incapable of making decision on their own. Okay, well, what goes in the anesthesia table is not the patient's decision. It's what all time, if something is going wrong in emergency, what decisions the uh, doctor has to take. Okay, that becomes under Parsons theory. So the patient is completely under the state of submission because they are in certain health condition. But in other form, in today's world, when we are living in a patient-centered world, okay, in this case, we can't follow Parsons theory. Okay, and even for doctors, what Parson has said is the doctors are expected to apply all their special knowledge and skills for the benefit of the patient. The doctors should not work for the benefit of themselves. They should completely work for the benefit of patients. Okay, but that is one of the important idealistic part of the Hippocrates oath. That is true. Okay, and they have Parshall has also told that the doctors has to be completely detached, emotionally detached, and be very objective. Okay, the doctor has to be very objective and completely emotionally detached from their patient's condition. So even that we can't apply in today's world. Okay, at some point of at some time the doctors do get emotionally attached, because if it is a case they are treating for so long. Okay, and they have a very good doctor patient relationship maintained. Okay, they have a very friendly relationship maintained. Obviously the doctor's emotions will also come into play. So that is what Parsons theory is. Then we have Hippocrates oath, very similar to Parsons theory. Okay, it mainly underlines how your actions should benefit the sick. Okay, and keep them from harm, do no harm. Okay, that is basically Hippocrates oath. But there are certain prohibitions to Hippocrates oath. For example, Hippocrates oath will prohibit abortions and poisoning. Okay, that is, it is a very debatable question. Poisoning in case of, like, what is euthanasia. Okay, in certain cases when you are trying to bring death upon the patient with their obviously with their and their patient's consent. Okay, certain kinds of drugs are used. uh, okay, certain kinds of drugs are used, so that comes into the poisoning section. And when it comes to abortion, that is also very debatable even in today's day and age, because of certain religious clashes do come with certain people are pro life against the against the woman's body uh, matter league. Okay, so in Hippocrates oath, it is classically said they abortions are prohibited, poisonings are prohibited. Okay, so that's the drawback in Hippocrates oath. And it is also very centered, what doctors have to do, but what are the patient's rights, what are the patient's autonomy, about that Hippocrates oath doesn't speak much. Okay, then you have American Medical Association oath, which was before 1960s. Now they have changed the oath, but the Medical Association oath, which was before 1960s, that was also very much based on Hippocrates and Parsons theory. Then you have paternalism. So just by the name itself, what do you understand? What do you mean by paternalism? Anyone in the chat box? Yeah, protective, very similar to being kind of parents. Okay, kind of being quasi parents, parent like. Okay, that is paternalism. Again, in paternalism, it's the very same thing like Parsons theory, where uh, there is a parent child kind of relationship between the doctor and the patient. Here the doctor acts like a parent. Okay, and treats the patient like a child. For example, in this image you can see paternalistic approach means do what I tell you, and how it is opposite to the patient centered approach. Tell me about your thoughts. Just by looking at these two images, you will understand what is paternalism. The doctor will say these are the things you have to do, these are the things you should not do, and what the patient wishes to do, or what the patient's thoughts are about these things which he has to do or not to do, it is not taken into account. What the doctor says is the final verdict, and that has to be followed. So that is a paternalistic approach or paternalism. Other examples are given in the textbook, just you can go through that. I guess you have understood what these terms means. That is more than enough. Okay, Then coming to modern variations, in the modern world, what kind of models we use. Okay, so the first one is the Robert Wedge mold model. So that is on page number 41. So this is one model, Robert Wedge model. It talks about 4 different models. Okay, so the first one is engineering model or informative or consumer model, another names for this. But in your textbook, they have used engineering model. So just stick with that. Understand it by engineering model. So in engineering model, they have said that um, patient is like a consumer. Okay. Consumer, you know how the consumers are in the market. They will make the decision on what they want. Okay. So engineering model says that consumer, that is a patient, will decide for himself or herself what they want to do. Okay, the doctors just have to give them the facts without any opinions from the doctor's side. Only the facts has to be given to the patients or the consumers. Okay, without any opinions or without any slightest coercion from the doctors has to be very unbiased in engineering model. Okay, very unbiased. These are the truth, these are the facts. If you do that, you will get this kind of result. If you go for that, you will get this kind of result. What do you want to do? Okay, that is how the doctors will state the point or explanation. So consumers, the patients, have the complete right to choose what they want for themselves. So then comes the priestly model. The word used in the textbook is also priestly. Again, it is a parental model, parent-like parentalism. Okay, so here the doctor knows everything. The patient has to be completely submissive. Okay, whatever the doctor says has to be blindly followed by the patient. Patient here has no choice in their treatment modality. That is priestly model. Then you have collegial or interpretative model. Okay, in collegial or interpretative model, what happens is both the patient and the doctor, they have equal rights. Okay, there is a goal. For example, um, a new kind of surgery has to come into form. Okay, for example, if somebody has knows about the story behind um, the conjoined twins. Okay, the conjoined twins who were joined by their head. Okay, this surgery took place in the John Hopkins Hospital in the USA. Okay, by Dr. Ben, and he had to separate the conjoined twins who were joined by the brain. Very difficult surgery. That kind of surgery was never done in the history of, in the medical history. It was the first kind of surgery, and that was the task, to have a successful surgery. Okay, to have such an innovative new surgery and to have success in that surgery was a common goal and common challenge for both the patient as well as the doctor. So here the doctor and the patient, in this case the patient was two kids. Okay, two girls, that their parents will become the patient party. So the patient party and the doctors had a very collegial kind of relation. Okay, they were both striving together and they had such a built of trust in each other. Okay, they because to give their kids to such a innovative surgical process which was never done, and such a risky surgical process again which was never done, you should be very trusting in your medical fraternity. Okay, so that's collegial approach where the doctors and the patient, they will share a very common goal. Okay, and they are given a very challenging case, and they will together, they will come to certain decisions which is beneficial for both of them. And the common challenge here is not monetary gain, not expense, but to get a successful treatment out of it. So that is collegial or interpretative model. Then you have contractual model. For example, all the medical researches that takes place, that's a contractual model. At any point of time, the patient has the right to come out of this contract. And also the same applies for the doctors. At any point of the research, the doctors have the right to come out of this research. So it's very legal based, it is a very legally bound kind of relation between the doctor and the patient. The entire relation is based on a particular contract or a legality associated with that. Any party can leave the contract at any point of time, uh, when the contract closes, the contract time period closes, the relationship also closes. For example, in insurance, okay, all the insurance companies will have certain doctors in their empaneled hospitals, okay, and when you are buying an insurance policy, these doctors have the right to assess you for any underlying medical conditions or not. So these kind of relationship between the assessing doctor and the patient who is going to be insured, that's also a contractual model, okay. There is a very less trustworthy, or very less confidence in this kind of DPR relation. Conventional, it is not given in the textbook, so don't worry about that. Just understand the meaning of engineering, priestly, collegial, and contractual model. That's it. So this was Robert Veitch's model. Then coming to Stewart and Porter model. So please take the screenshot of this, okay? Because the table which they have given you in the textbook, page number 43, you may find it confusing, but this table is very much easier, much more clearer than the table given in the textbook. So take the screenshot for your future reference. So under the Stewart and Porter model, you have 4 categories. One is paternalism, okay. Then you have consumerism, default, and mutuality. These 4 blocks, okay, they are the 4 main categories under the Stewart and Porter model, okay. And the how each of this block differs from each other is the amount of control the physician has and the amount of control the patient has. How different it is or how similar it is, based on this controls, physician's controls and the patient controls, each of these 4 blocks will differ from each other, okay. So first, talking about the paternalism, okay. So this block, paternalism. So just by looking at the image here, what do you think, who has a more control over decision making? In the chat box you can reply. In paternalism, obviously the doctor has much more control about the decision making, okay. Paternalism means paternal, doctor has the much more control over what has to be done, how it has to be done, okay. The doctor has a the patient will have very low control, usually they will be very submissive, okay. Then coming to consumeristic, okay. Here, as I told earlier, doctors will share everything, every possible information, but who will make the decision at last? In consumerism, just look at this table and say, who will make the decision, who will have the final say in decision making in consumerism? No, in consumerism, patient will have the final say. See, in consumerism, patient's control is high, physician's control is low. This is how you use the table. See consumerism and see how much control the physician has. It's low. See how much control the patient has. It's high. Okay, patient's control is high. So patient will have the final say in consumerism. What doctors will do here, will just state the facts, possible outcomes, things that may go wrong, which each of the different treatment modalities available. The patient will choose what he or she wants to go ahead with, okay. Then coming to default, this first one here, default, okay. Who has more control? How is the control relationship in default? In default, both is low. Just see, low and low. Patient control is low, physician control is low. Okay, in default, just see the orange box here, which is the coinciding orange, which row and under which column this particular class comes. So in default, both physicians control as well as patients control is low. What will happen here? Anyone in the chat box? The physician also doesn't have control over what to be done. The patient also doesn't have control over what to be done. What will happen in this case, in this kind of scenario in default? What will happen? Just imagine yourself. You're going to a doctor, doctor is giving you certain things to do, you do not want to do. What will happen? Dissatisfaction, and finally, it will not lead to anything good. Okay, you may have to change your doctor, or the doctor may decide not to treat this particular patient. Okay, you will not achieve any positive prognosis through this kind of default kind of category. Then finally, mutuality. In mutuality, physician also has a very high control, patient also has a very high control. See the row and column for mutuality. The row is patient has high control, the column is physician has high control. What happens in mutuality? What kind of relationship will be this? Think about it. Yeah, it will be quite satisfactory, because sometimes what we may think, if both the parties are having high control, it may lead to conflict. Okay, but it doesn't happen like that. Okay, here what happens is a patient has high control means patient has enough knowledge. A doctor is giving enough knowledge to the patient. Okay, enough knowledge to the patient. So patient is speaking from the point of high knowledge, or a patient is speaking from the point of being better informed. Doctor is speaking from the point of being better skilled. Okay, so in this case, there is a openness for new questions to come from the patient side, clearing the doubts. Okay, and commonly they will achieve a common goal. That is what happens in mutuality. Okay, there is a room for patients to ask doubts, clear any misconceptions. Okay, a room for discussion is given. Okay, the physician has a high control, but in a way that he or she allows the patient to ask questions and be sure of what kind of treatment you are going. Are you sure about that? Like that, you have to assert, the patient has to be assertive. Yes, I am sure, I want to take that. Okay, that is the kind of relationship that builds in mutuality. Both have high control, but it comes from a different form. These high controls come from different places, one being better informed, other being better skilled. Okay, so that was Steward and Porter model. I hope you have took the screenshot of this, because the table given in the textbook is not that explanatory. Then we have the SAS and Hollander DPR model. Again, it works on 3 different categories, SAS and Hollander DPR model. So first is activity and passivity, parent infant. Okay, what do you think will be the meaning of this? Here the doctor is like a parent, the patient is like an infant. Just imagine a relationship between parent and infant. Will the infant take decision for themselves? Can infants take decision for themselves? No. So here the parent, that is doctor, is active. The infant, that is a patient, is passive. Okay, so this kind of scenario you can see in critical care, like in ICU, acute care area. If the patient is in comatose stage, okay, under anesthesia, when a surgery is going on, in emergency trauma, or when a patient is in delirium, it's a mental condition in which the patient doesn't know about his surroundings, what is happening, etc. So in that case, the doctor has to take this kind of behavior. The doctor has to take parent infant behavior, because he or she knows that the patient is completely in under his control. The patient is completely under the doctor's and the caretaker's control, and the doctor has to act in the patient's best interest. So that is activity and passivity, parent infant kind of relation. Then comes guidance and cooperation, parent child. Okay, what do you think will be the dynamics here? What do you think that will be the dynamics here? Yeah, there will be mutual cooperation in terms of the patient will be given choices, okay, but choices will be from the parent side. That is, the doctor will choose certain treatment, and only that kind of choices will be given to the patient. Okay, doctor has much more control, but at least the patient is getting choices to choose from. Okay, that is happening here. The patient is at least having choices to choose from. For example, a patient who's admitted in any ward, not in critical care ICU or anything, just a normal general ward or private ward. Okay, in that case, when the doctor comes, pays visit, okay, here the patient is much more in control of the decision as compared to when he or she was in intensive care. Okay, so here the patient has a choice. For example, when you are okay now, the doctor may say, okay, now you are getting better, you can either stay for one more day or we can discharge you today itself. Okay, so that kind of choice, that's the guidance and cooperation, and have giving health education at the time of discharge. These things will come under parent child kind of relationship, that is guidance and cooperation. Then mutual participation, adult adult. What kind of model will this be? Any examples which you can give? Mutual participation, a conversation between two adults. What kind of relationship this will be when it translates to doctors and patients? Here, for example, in the pandemic now, not every corona cases has to go and get admitted in the hospital. Okay, just via practo or via telecommunications. Okay, a doctor can assess through phone and tell you what to do. Okay, the patients can, yes, very well do the self care with the guidance of with the guidance of the doctor. Okay, through telecommunications, or the doctor has told them these are the things which you have to do. You can do these things at home. For example, taking insulin on their own at home. Okay, drugs are prescribed to the patient. To follow that, they will go home and have the drugs at the correct time with the correct dose and everything. These things the patients can take care of themselves. Okay, the symptomatic management of corona that you can do at home. Okay, that's a mutual participation. Doctors will call you, ask you about the temperature, what is the pulse oximetry reading, what is the BP, what kind of symptoms you have it resided, has it increased. On through phone, you can do a self assessment on yourself and tell the details to the doctor. That's a mutual participation. It's an adult to adult kind of conversation. Okay, the patient here will use the expert advice from the doctor and try to play an active role in his or her own health. Okay, so that is Shaz and Hollander's DPR model. Then you have principles, basic principles of doctor-patient relationship. There should be autonomy. The patient has the right to make decision for themselves. Beneficence, whatever you do should be should be causing benefit to your patients, not harm. Non-maleficence, do no harm. Fiduciary trust, I have explained that. There are people who completely trust you with their best interest. You have to work in others' best interest. That is the medical fraternity. Justice, follow the patient's rights, right? Or the patient rights which they already have legally. Follow that, you are following justice. Veracity, be truthful and be honest to your patients. Do not hide any important facts from them. Confidentiality, maintain their medical records, okay, until and unless there is a court order to bring forth the medical records. These are the principles of a positive doctor-patient relationship. Deteriorating DPR, commercialization of medical education. Nowadays, medical education, you know how pricey it is. After completing medical education, how many of the students would want to sacrifice their career for the benefit for others, and how many of them have to make money so that they can repay their loans or debts which the cost of medical education has cost. So that is affecting the doctor-patient's relationship. Okay. Poor communication skills, personal touch is going on, is completely over from the medical field. Mostly it is over. So poor communication skills. Increased specialization. For example, earlier we had the thing called as family doctors, and now we have specialist, super specialist. Okay, to which kind of doctor you will feel much more comfortable in opening up to? Will you feel comfortable in opening up to your specialist or super specialist, or to your family doctor? Yes, to the family doctor. Okay, because there is a personal touch to it. So increased specialization means you will talk to that particular specialist only based on that particular body part, or only based on that particular disease. They will not ask much about your general well-being. The family doctor usually does that. Okay, so that's a personal touch. So increased specialization in medical education has led to deteriorating DPR. Commercialization of society, even doctors wants to have a stable, a good life. They also want to earn well, so they are also looking for profits nowadays rather than the missionary profession which the medical profession was. Turbulent society, now we can see the political scenario in the world throughout. Okay, the society is very polarized, very much polarized. So there are frequent riots, violence, okay, political debates, um, friends breaking up. Okay, all kind of situation we are facing in the society like this, which we are living in. Okay, so in this case, normally the people will become very edgy, even for small mistakes and all. They will be creating ruckus and fights over this. Okay, so that's how we are facing so much of medical violence, doctor results. Okay, because the society in general is becoming very turbulent because of various other social factors and political factors which is playing out. And role of media is responsible for bringing about lots of news on medical errors, how doctors are into corruption. Okay, different areas in which there is a general thinking about the public that doctors are working only for profits, not for their general well-being. So media had a big role to play in this. And lack of holistic attitude. So nowadays, because of specialization, only one body part or one particular disease condition is in focus. Doctors are not thinking much about the general well-being of the patient, what is their mental status, how their mental health is. Okay, what are the cultural factors of this particular patient that is affecting their health. Nobody is thinking about that or having a talk about that. So that is holistic attitude is being lost. Then rise of managed care, involvement of management. Okay, not the medical fraternity. When we talk about hospital, it's medical fraternity as well as a management. So in too much of involvement from the management side in the clinical activities, even if the doctor wants to work for the benefit of their patients, but under the profit making pressures of the management, they have to bow down to certain circumstances that do happen. Doctors want to help their patients, but because of the pressure of management, they are not able to do that, because management obviously looks for profit making ideas for the hospital, and not necessarily every doctor will support that. So that is rise of managed care. Then IT revolution, the patient who is too much informed and too much misinformed because of internet or because of IT technologies. Too much of misinformation is out there in the world, and based on that, when the patient comes into the hospital based or already making conceptions, already having a certain set of thoughts and opinions, and then coming to the doctor, it is very difficult to break that mold of misconception from the patient's mind and give them well information. That is very difficult for the patients, for the doctors to do these days. So that is how IT revolution has deteriorated the doctor patient relationship. When you have patient rights, I guess everyone knows that courtesy and dignity. Every patient has the right to be treated with the courtesy and dignity, right to refusal of treatment, right to information, right to refuse the treatment whenever they want, estimate of expenses. Before you give the treatment, tell them how much it will cost. Don't wait after the treatment to give them the shock of the cost. Before treatment, before doing any surgery, tell them the estimate cost of the surgery, the stay, everything. The upper limit of the expenses has to be mentioned to the patient before you start any treatment. Itemized billing, each and everything used in the patient care has to be itemized, because when you get discharged from the hospital, you must have seen a whole lot of bunch of discharge sheets and billing sheets will be given to you. Each and every item used in your care will be billed, so that is itemized billing. Non-discrimination, do not discriminate anyone based on the religion, caste, creed, their social class, race, nationality, nothing. Emergency care, every doctor has the right to perform emergency care. Even if a small emergency care can save the life of the patient, it has to be done. Do not refuse emergency treatment. Express grievance. When the patient, if any of the rights which you had not maintained while giving any treatment, okay, you have deviated from following the rights of the patient, or caused any near miss events or any sudden events which has caused a tremendous loss to the patient, okay, in terms of any physical deformity, any mental handicapness, or anything that has caused severely to the patient, you the hospital is responsible to aggrieve them, to give them the grievance consolations and everything based on what the court of law has suggested, okay. So that's how grievance has to be taken care of. If any rights that was not followed, or any tremendous hurt or loss was caused to the patient during their stay, grievances has to be given back. Rights of doctors. Every doctor has the right to turn away patients whom they do not want to treat. The doctor has the right to select the drugs from n number of variety available in the market. The doctors will have the right to select the investigations and treatment what they want to perform from the best of their knowledge. If the patient is refusing certain treatment, make sure you take a written refusal from the patient who is refusing, or from the patient party who is refusing certain treatment. The doctor has the right to delegate their rights and powers to other doctors, because if in case of their absence, other doctors have the right to take care of the patient with the willingness of the patient. Other doctors can have the right to care for your patients if you are not present with your permission. The doctors can decide on the visits, what fees they want to charge, maintain the medical records until and unless it has been ordered by the court to be shown. Okay, so these are the rights of the doctors. Any doubt in this? Please mention in the chat box. Any doubt? Other topics which I have not took, just read through that, like for how to, what are the responsibilities of the patient, how to improve the relationship, these how to improve a bad relationship between doctor and patient. These things you have to do self study, you have to do